Hi, everybody. We're on our last stretch for inflammation, and our focus is going to be on what the systemic responses are towards an acute inflammation. So, yes, we've discussed acute inflammation into eternity, it seems, but what we didn't take a closer look at yet is how all of those cytokines and other inflammatory mediators and those plasma proteins, they're all, dumped um, into the tissues, but they eventually trickle into our blood as well. And once something is in the blood, as you know, the blood takes it throughout the whole body, which then leads to responses all over the body. And this is what we call the acute phase response. I know this is kind of a strange name, but that's what it's called. It might at times be given a different name, but I will be using the term acute phase response or APR. What we're going to look at is that some of these systemic responses are going to be related, excuse me, to changes in an interesting set of proteins that are called the acute phase proteins, or abbreviated APP. We'll discuss fever, which are generated or which is generated by means of pyrogens, and there you see pyrogen as in fire, right? We're going to talk about the sedimentation rate of erythrocytes, the increase of white blood cells, and then something called negative nitrogen balance. So we need to look at 1, 2, 3, 4, 5 major items here, and then we're done with our whole discussion of inflammation. So when an acute inflammation is triggered, and you know how that works now, either a pathogen has invaded or we have some kind of an injury, cancer. Um, basic, Basically, we're going to see that lots of neutrophils arrive initially, followed by macrophages, even other white blood cells, and they dump a bunch of cytokines, even other inflammatory chemicals into our blood. And that is actually going to then tell the liver cells, the hepatocytes, to start cranking up a certain type of protein called the APS, or the acute phase proteins, particularly the positive acute phase proteins. So positive acute phase proteins, they actually increase during inflammation. So positive goes with the arrow up. Negative APS also exist. They decrease inflammation. Of course, we're going to primarily focus on those that promote inflammation. That is the positive APS. Cortisol can actually play a role in regulating APS. Remember how cortisol is one of the hormones that decreases inflammation and decreases the immune response. And these AP proteins can play a very important role in um, increasing the chance of sepsis. So here we see some examples of acute phase proteins that are going to increase in their concentration during inflammation. And some of them you are actually already familiar with. For instance, you're familiar with complement factors, even the mannose binding lectin, right? Um, Fibrinogen and other clotting factors are considered to be positive apps because, as you know, they're all involved in the inflammatory response, the acute inflammatory response. Another protein that you might see listed on a blood report that you might need to get at some point, you might get blood drawn and then they do a blood analysis. When they're looking for something, you'll most likely see CRP, or C-reactive protein, listed on there, which is a very definite clinical marker for inflammation. Let's say that a person has had um, a heart attack and this person has atherosclerosis, so hardening of the arteries. This would really show up in an analysis of their blood. So C-reactive protein can also, by the way, opsonize or tag microbes so that phagocytes can find them easier and munch them up. So there are also proteins in our blood that decrease in concentration during inflammation, and we refer to them as negative APs. So we're going to see a decreased production in albumin or antithrombin. Albumin really doesn't have anything to do with inflammation, which is why are called probably negative acute phase proteins. Uh, but the thing is that their concentration begins to drop. Why? Because our body starts to take them apart so that we can use their amino acids to build to the positive apps, which can then increase in inflammation and acute inflammation. So when we see a drop, let's say in albumin, that might suggest to a doctor, oh, wow, there might be some form of inflammation going on. So another clinical marker. So that brings us to fever or pyrexia, which is created by chemicals we call pyrogens. And so there's two forms. There's the endogenous ones that are produced from within our body, interleukins in particular. So IL-1, the IL-1 family is particularly good at stimulating our prostaglandin E2. Remember how it then can communicate with the hypothalamus to trigger a fever via manipulation of the temperature control center of the hypothalamus. Remember, we discussed the prostaglandins when we touched on the eicosanoids and the arachidonic pathway. But chemicals produced by microbes, like lipopolysaccharides, can also trigger the interleukin 1 production and therefore lead to a fever. So here's a quick review of how the breakdown of phospholipids in the cell membrane by means of phospholipases creates our famous arachidonic acid, which can then be converted into prostaglandins such as thromboxane, and here we have PGE2 and also the leukotriene. So the PGE2 is what can communicate with the hypothalamus, impact the temperature control center, which then triggers a fever. And remember too that we often might take a fever reducing medication, and that is going, or those medications are typically going to impact COX-1 and COX-2 enzymes, which prevent the conversion of arachidonic acid in PGE2. Another clinical marker for inflammation is the ESR, which stands for erythrocyte sedimentation rate. Now, I need to point out to you, though, that this is non-specific. In other words, what that means is the only thing that we can conclude from an increased ESR is that there's inflammation somewhere in the body. We don't know where or what kind, right? So it's non-specific. So what does that mean, an erythrocyte sedimentation rate? Well, it is, as you can see here in these tubes, we literally put some blood in a tube and we measure how fast red blood cells sink to the bottom of the tube. The faster the ESR, the more inflammation there is. So for instance, if fibrinogen is elevated in our blood, which is a positive AP, remember a positive AP, acute phase protein, is increased during inflammation, this fibrinogen can bind to red blood cells and then make the red blood cells precipitate even faster to create a faster ESR. So all of these different clinical markers together on a blood report can help a doctor perhaps pinpoint better where or what the problem is in a patient. A severe increase in white blood cells called leukocytosis could also be indicative of an inflammation. And there are specific terms for that. So if you have an increase in the lymphocytes, you call it lymphocytosis. Increase in monocytes, it's monocytosis. And then all of your granulocytes, neutrophils, eosinophils, and basophils, when they see an increase, they get the suffix philia at the end. So it's neutrophilia, eosinophilia, and basophilia, right? Again, clinical markers of inflammation. Now, what we can do is not just look at all of the white blood cells. And by the way, I do need for you to know what a normal white blood cell count is, which is anywhere from 5,000 to about 10,000 cells per microliter of blood. Sometimes this is expressed, as you know, probably as cubic millimeters of blood, right? So 4 to 5,000, this could be about 5,000 perhaps, to 10,000. So we're talking about the thousands, not hundreds of thousands like we would for the platelets, or millions, which we would for red blood cells. Now we can look at the individual numbers of white blood cells, and then we can get more specific information. So we refer to that as a differential white blood cell count. So try to memorize some of these things. So if we have neutrophilia, then that might suggest that there is a bacterial infection, an acute bacterial infection, eosinophils, parasites. Lymphocytes is going to typically mean, oops, we have some kind of an acute viral infection. Chronic inflammations are typically represented by elevated monocytes, or we might see elevated basophils. For instance, people who suffer from rheumatoid arthritis, they might see an elevated basophil count. Basophils are very rare in our blood. They're the lowest number, or when we compare all white blood cells, the basophils make up the lowest number of all white blood cells. So it's easy to recognize when they're elevated. IBD, by the way, stands for inflammatory bowel disease. Finally, we need to take a look at what is meant by a negative nitrogen balance, which is one of the systemic effects of an acute inflammation. Remember, that's the focus here of our discussion. What are some of the systemic effects in response to an acute inflammation? We've also looked at some of the results, as you noticed, when we did the differential white blood cell counts for chronic inflammation, but our emphasis is on the systemic effects of acute inflammation. So before we can get into what is meant by a negative nitrogen balance, we need to first figure out what on earth is meant by a nitrogen balance. Well, a nitrogen balance is reached when our amount of nitrogen intake, and subtract from that, I should say, the nitrogen loss, meaning you lose it by mostly urinating. That provides us with a nitrogen balance. In other words, how much nitrogen do we still have left in the body? So we can do that by measuring the blood, or even the amount of urea in the urine. So now it'll make more sense what we mean by a negative nitrogen balance. This means that we're literally excreting a lot more nitrogen than we're taking in. Now, when would this happen? Well, again, we're talking here about inflammation. And for inflammation, we need a lot of proteins. We need proteins that are the APPs, but we also need proteins to make components of the complement pathway, the clotting factors, all of the, just to name a few. The cytokines are also based on amino acids. They might not be big proteins, but they're made up of amino acids as well. And so what happens, in order to make all of these proteins, that play a very important role in inflammation is that the body begins to literally sacrifice proteins that are not really important in inflammation. So we see protein catabolism occurring, right? So that we see uh, a net decrease in total body protein. So we're breaking down proteins to release amino acids so that they can be used to make the kinds of proteins like the APs that we desperately need for inflammation. And so that's how we end up with that negative nitrogen balance. We may actually even see that all those proteins that we like to stuff in our skeletal muscles, you know, your actin and tropomyosin and troponin, um, they're going to be broken down again to release amino acids to make proteins that can partake in um, um, inflammation. So one of your course objectives clearly states that you need to have a good feel for what the clinical markers are of inflammation. So I have nicely listed them for you here. Remember, we're going to see that there is going to be an increase in positive AP proteins and a decrease in negative APs. We're going to see a change in the number of leukocytes. Typically, we're going to see an increase in various leukocyte, white blood cells. It all depends on what kind of acute inflammation or even chronic inflammation is occurring, which then leads us to that differential white blood cell count, which can pinpoint better what kind of inflammation is occurring. Um, Inflammation typically means that we're going to see an increase at the rate with which red blood cells drop to the bottom of a blood sample in a tube. So we call that the erythrocyte sedimentation rate. A lot of that has to do with the fact that during inflammation, we have an elevated level of fibrinogen, as we learned in the coagulation system. The fibrinogen can bind to red blood cells, literally make them heavier so that they sink towards the bottom faster. And then we just talked about the negative nitrogen balance, where proteins that are not really important in inflammation might be catabolized, and so that the liver can make, for instance, new clotting factors, new AP proteins. So that wraps up our discussion of the acute phase response. Remember, the acute phase response is really just a rather strange way of us talking about what are all the systemic responses that we see towards an acute inflammation, primarily an acute inflammation. And so let's do a little bit of applying what we've learned. We've learned about cytokines. We've learned about ROS in our cell injury topic. We've learned about cell death, so all kinds of cell injuries. We've learned about inflammasomes. Um, so you might have come across articles that you've read, you might have heard that people who struggle with surviving a SARS-CoV-2 infection, meaning people who have a serious bout of COVID, go through something called a cytokine storm. And what is this really? Well, somehow the invasion of the virus, and of course the name of the virus is SARS-CoV-2, we tend to call it coronavirus, but this is the specific name. It creates this very nasty hyper-inflammatory immune response um, that starts at the level of the epithelial cells in our respiratory tract, our trachea especially. And what the epithelial cells do is they produce a whole bunch of ROS, which then triggers possibly the death of cells by means of apoptosis and necrosis, even to some extent. But it also leads to the synthesis of inflammasomes and something called nuclear factors. And these nuclear factors, they're going to um, impact the transcription of the genes in our DNA that code for cytokines. So suddenly, all of these chemicals are produced that are going to increase how fast genes are transcribed that code for cytokines. And that's where we end up with that cytokine storm effect. So again, here we have our spiky coronavirus, the SARS-CoV-2. It penetrates or gets into the pseudostratified ciliated columnar epithelial tissue of our trachea, um, and then ROS is produced that might lead to cell death, but also a nuclear factor and inflammasome that somehow sets off all of our immune cells to go into overdrive and produce vast quantities of cytokines. And not only that, SARS can even activate the generation of more cytokines via the TLRs or the PRR activation. So that's what leads to the cytokine storm. And that has all kinds of consequences because all of these cytokines, as we just learned, end up in the blood and have systemic effects. And when there's such high levels of cytokines in our blood reaching our various organs, all of our organs or many of our organs can get affected to the point that these organs begin to fail. And of course, that could potentially lead to the death of the person. So here you see a list of the various horrible consequences of the cytokine storm. A person might end up with acute respiratory distress syndrome. It can get even worse, and we can start suffering from sepsis, which then ultimately might lead to multiple organ dysfunction syndrome or MODS, and that most likely is going to lead to death. So, phew, we've made it through inflammation. This was an intense topic, but very interesting topic. I hope you learned a lot. And good for you that you made it this far. So onward.